Good morning. Welcome to this screening of the remote sessions recorded at the Paris International Forum on Quality and Safety in April this year. Welcome on behalf of the Health Quality and Safety Commission of New Zealand, who have bought a licence that allows these sessions to take place. My name's David Gallen. I'm a board member of the Health Quality and Safety Commission. I'm also an intensive care doctor at Middlemore Hospital and work at Ko Awatea as the Director of Clinical Leadership. Together with me today, we've got a panel of stars, I'd like to say, and I'm going to introduce them. The first person on my left is Jim Easton. Jim Easton used to be the Chief Executive of the York Trust in the north of England and developed a reputation there for brave change in the improvement world. And went on to have a stellar career running a strategic health authority, and now has turned to the dark side and is working for the government. On his left is Jason Leitch. Jason Leitch is the clinical leader for improvement for the whole of Scotland. Jason is a Glaswegian, as you will soon hear, and he is also an oral surgeon and has probably fixed more mandibles than anyone in the world. And to Jason's left is Frank Federico, who is the Executive Director of Strategic Partners with the Institute for Healthcare Improvement. And Frank has got a long and stellar career working, an ex-pharmacist, I believe, actually, who has been working in the improvement world for quite a number of years. This introduction to the day really does set the scene for the program that you have put together. So this is a general discussion that we're going to have around a number of issues, and those issues are the value proposition for an investment in quality, particularly in these tough financial times, and how that investment might shape up, and how do we actually channel that investment and those strategic thoughts and ideas into actual measurable results and outcomes. And I'm going to open that up for Jim to start.
Thanks, David. Well, I think it's really interesting that whether it's in New Zealand or around the world, we even have to ask the question in that way about whether there's a value proposition for investing in quality. And it speaks to a fundamental problem in the mindset of those of us who run healthcare or deliver healthcare, which has been for many years that quality is a financial burden. That if you want to improve quality, you need more of everything and it costs money. What it means is that executives are frightened of the idea of quality. For them, it looks like opening up financial pressures they can't afford. And clinicians, great clinicians, get locked into this box that it's a further driver for increasing investment in services. And we walk out of our hospitals and our clinics, and in the rest of our lives, we expect something completely different. We expect, whether we're buying cars or computers or other services, that the quality proposition is also driving value. And we just need to grow up and bring that same understanding into our healthcare lives. Truth is that pretty much, not for every issue, but pretty much for most issues, the things that drive quality are the things that eliminate waste, error, duplication, harm in healthcare. And managed intelligently and also with a degree of toughness, they are also the things that will make healthcare affordable. And you know, I'm a healthcare executive, and the years that we spent thinking that we knew better than Toyota or GE are pretty shameful years. And we need to get the skill set. If we've got to face a problem about driving improved quality, dealing with a growing population with growing needs from a tight budget, then this is the toolkit. And in England, faced with our biggest ever problem, £20 billion over 4 years, and a need to sustain the quality gains we've made, we have turned root and branch to quality improvement in our most difficult time as our basic toolkit for facing that problem.
Thank you. Scotland has been helped to a large extent by the IHI as well. Isn't that true? You've got quite an interesting relationship and an interesting approach, haven't you, Jace?
We have. So 5 years ago, I came back from IHI having been a fellow there, and we had a UK prototype, particularly around safety, in 4 hospitals, one of which was in Scotland, that Frank had helped lead. And we decided, quite riskily, if that's a word, to take that prototype to scale. So we decided to grow up, in Jim's words. And I love that. I love that expression. To take a serious attitude, to stop messing about, and take this thing to 37 hospitals instead of one hospital, and not spend too much time. Somebody tried to convince me to cut the country in half and apply it to one half and not the other half and see what happened.
That would have been a research scientist?
Correct. So we decided not to do that. And we decided that it was unethical not to eradicate central line infections across every hospital, or to try and do medicines reconciliation in every primary care environment. And that's what we did. And the relationship with IHI has helped us because of principally the expertise, but also the partnerships they bring us. So the partnership with Coahuila, the partnership with Cincinnati Children's Hospital, the partnership with the Institute in England. IHI is the kind of broker for all those people, one, and the organisational change. So we get to know what Jim is doing. We get to know what Frank is doing. The only other thing I'd add early in the conversation is I've recently moved job. I've been in roughly the same job for 5 years, but from a clinical job to a policy job. But recently I was kind of promoted, and I don't know if it's really promotion, but so I now sit on the board of the Scottish healthcare system, and I'm a director of that board. And we had the income and expenditure account. It's the first time I've ever seen the income and expenditure account for the whole system. Now, Jim's lived that life for years. I'm a surgeon. And the bottom line of the income and expenditure report was £11 billion for the year. And I looked around the table and I said, guys, there's £11 billion. Why are we so worried? What is actually the problem? And it seems to me we're far too focused on the 3% or the 4% or whatever it is, and not on the 98% or 95% of the money we actually do have to invest. Now, we need to make the savings. We need to get cash released. But I think we have quality things that can do that. But fundamentally, Scotland has £11 billion to spend on its healthcare system. If we can't do it for £11 billion, I'm not sure why I'm at that table. So I had a kind of penny drop moment where the value proposition became very real for me. And Jim's probably lived that much more often than me.
Population of Scotland?
About 5 million.
It's very close to us, actually.
Yeah, about 5 million.
We're quite similar, actually, countries, in fact, and similar sort of backgrounds too, I think.
My caricature of you is you're more optimistic than us, but I'm not sure that's...
Well, that's a low baseline.
So I want to add to that. If we think of how we deliver care, we have lots of opportunities to do it more effectively, more efficiently. And you think of the value proposition, we do have lots of ways that we can save those dollars or pounds or whatever they may be, and still deliver the care that patients should be getting, the evidence-based care that allows us to achieve those results that the patients want. So what is the value proposition? Well, look at what we have. I don't like to use the term waste because people do a lot of good work, but there are better ways to do it that will provide you with more efficiencies, more ability to use those dollars in a different way, those funds, and ultimately the outcome, getting to the right outcome. There's so much variation in how we deliver care. We need to wipe that out and make the variation only for those patients who truly need something different, not because I choose to do it one way, Jim and Jason decide to do it another. We don't see that as bad, but it is. It's what we should be eliminating. If you go to Toyota, they've standardized how they make their cars, yet they always look for the opportunity to do it better. I was just reading Stephen Jobs' book about the Apple work that he's done, and he was so meticulous about the pieces that nobody would ever see, because he thought that quality was extremely important. And you would say, so why? We could just eliminate that, not worry about it. But he said, no, we would know that it's not appropriate.
There's a few great terms I like, hit and hope, spray and pray, making this, this is, good, this rhetoric,
Yep.
Turning that rhetoric into, measurable results is not that straightforward. And, well, actually, that's a question, actually, and you may have different views on that. But what are the elements here to turn that kind of strategic vision or aspiration or the goal that you have, the big, hairy, audacious goal, which is a term I don't use so much, being one myself, how do we turn that into a reality? There's some infrastructural requirements here, are there not? Some short-term or actually some long-term investments.
Yep. I don't think it's complicated, but it does require doing, and it does require discipline and focus. And so the things we've learned are all very obvious, but the key is to do them in a lined up way and to do them as a professional game, not an amateur sport. Again, you know, I know they'll be listening to this fantastic colleagues who are executives. Our reflection on ourselves as executives leading the English healthcare system was that we were kind of amateurish in our leadership. We'd collected a ragbag of approaches and ideas, and we wondered why we got a range of differential results. And so the components for us are relatively simple. Have a proper improvement method and have it everywhere. So, you know, have people properly trained in it. If you've got a game plan, the team need to understand what the game plan is. And I mean senior leaders, boards, senior clinicians, frontline staff. The good news about that is it's energising for people to do. But people have to get over themselves and be prepared to learn some additional skills. Line that up with the incentives in the system. Develop your leaders in a focused way. We found we were spending plenty of money on leadership development. We were just spending it in a completely dispersed way. Decide yourself what kind of leadership development you want to do. Not our game plan is to drive this through quality improvement. Get the leadership development that gives you the skills to understand the method and do it. The problem was not a resource problem. Have the right infrastructure to support those efforts, and that doesn't have to be huge. We spend you know, less than 90 million out of 100 billion, and we can leverage a lot of change from that. So to be honest, the money you need for some, you know, national, regional infrastructure is a rounding error. But if you haven't got it, you shouldn't expect to be able to make the kind of changes that are being described by my colleagues here. So there's nothing in there that's intellectually complex, but it requires attention. It's the attention to detail to make it happen.
This business of capability building and leadership are two really essential elements, aren't they? And I mean, can we tease that out a little bit, you two?
So we have designed it. So in exactly the same way Jim has just illustrated that you require a common aim, a vision, say, and that will vary according to your system and your structure and your position in that structure. And you need a method. So I sound a little pompous, but Deming, who invented much of what the theory behind what we're talking about, said it's all very well having an aim, but if you don't have a method, he wouldn't, in his old age, he wouldn't see you for an interview unless you could describe your method to him, because he was just fed up with people who came with no method. Don Berwick tells a great story of asking Deming, would this apply in healthcare? Deming didn't even speak, just turned and walked away. So, because you require the aim and the vision, and it has to be coherent, it has to be high level, and it has to be political. So you need politicians, you need senior clinical leaders, like we have in England and we have in Scotland, all agreeing to the same thing. And I think we sometimes take that for granted in our systems, and other countries are slightly jealous of that vision. And then you need a method. So your capability question, what's the method? Well, the method is we're going to teach everybody quality. Well, that's not much of a method. I can articulate now what that means in Scotland. For instance, we have a Scottish Patient Safety Fellows programme. We have about 60 mid-career clinicians who have been through a relatively low-cost, intense quality improvement thing where they get to come to this forum, for one thing. They get to meet the leaders of the global improvement world. And they do a project at home. They do 12 residential days where they meet the experts. We have improvement advisors. We've made 50 improvement advisors in partnership with IHI, using the best measurement teachers in the world who come to us, teach 30 at a time, move away, we use them.
They're
give
your
them
experts.
Yeah, and design your capacity. Do I need 5,000 improvement advisors? Of course I don't. But if I make 90, maybe we can then stop and say, okay, so how are we using that 90? Are there 50 of them that are functional? 40 we've maybe not done what we should, I don't know. And then the method is you've designed them within that capability. But you have to then link them to the vision and the aim and the goal that you've set for your country. Because if you're just sending them off randomly to do stuff will happen. But it won't be the big thing for the country. So I think capability, like improvement, needs a method.
So we learned from Jason in Scotland, we learned from Kaiser Permanente in the United States, Cincinnati Children's, and I'm sure there are many others that have been thinking through what this looks like. And I agree exactly what they said. Another area that we feel is important is the middle manager. We definitely have to spend more time with the middle manager. The middle manager translates the leadership goals and ideas to the front line. And we've forgotten that group, because we can teach the front line, we can teach leadership, we can have improvement advisors, but the people who really affect the culture at each ward level is the middle manager, so that's important. Going back to the proposition, is it worth investing? Kaiser Permanente has demonstrated in their early work that for every dollar invested, they've had $2 savings in return. So that's significant, and it all depends on the projects. Some are going to have more return than others, but they've invested heavily, much as Jason has explained they've done in Scotland, to what they call a dosing formula. So much training for leadership based on what they need to do and lead. Middle managers, improvement advisors, patient safety officers, frontline staff. Without that structure, it's not going to happen.
I just want to reflect on something that's come up in the conversation to date around the alignments necessary, for a strategy to be successfully operationalized. And we're talking about improvement here, but the principles around alignment and clarity of purpose are presumably the same. But how much of a struggle is that, and what are the alignments you actually need?
It's a great point, or at least it's one of the things that's allowed us to focus most significantly on driving more change. So I guess the truth for us is that we spent 7 or 8 years as fans of quality improvement, which we ran as a project in itself alongside other business that we did. And we found, as a result of that, we got fantastic quality improvement projects which demonstrated results. But the system, the other things that were going on in the system, which I think are the DNA, actually pulled those back to the norm or stopped them spreading. So the things we focused on getting, well, first of all, we've made improvement the game plan. And I think there are a lot of, and it's always good to talk with Kiwis about sport, sometimes through gritted teeth for me. But, I guess if you look back 30 years in sport internationally, in cricket or rugby, the idea was you assembled a group of talented players and they would solve the problem.
Yes.
And this kind of ruthless alignment and professionalisation of fitness and diet, analysis and measurement and application, a plan for the game that people could execute is not dissimilar. And I think we're because of our high talent individuals, our game plan in medicine has been you assemble a great group of intensivists and physicians and some executives, and they'll somehow solve the problem. Well, the problem's got more serious, and you need to professionalise. So we focus on alignment of the improvement with leadership development, which has been talked so well about here, the incentives in the system. This is a great example for us, is that we were leading quality improvement to drive out of hospital care, but our incentive system rewarded in hospital care. So you have to change the incentive system. You have to line the two up. Jason and I were corresponding about the tail of the surgical checklists. So one of my views is we should align the insurance method, the insurance that doctors have, so that you can't be insured to do surgery unless you're doing the surgical checklist. So it's spotting those opportunities for aligning the things that drive action in the system in the kind of a managerial or the behavioural system with the improvement. It's hard work. It's not intellectually hard. It just takes work. You have to identify, figure out who you need to talk to, understand what the change is, and do the work to follow it through. But I haven't found anything that's for which the biggest obstacle isn't our own mindset. That's usually the problem. There are people in England who believe that the pricing system is untouchable. And we have to kind of work around it in order to drive quality. Well, I don't think that's correct. We have to change the pricing system to support the quality improvement that we want. So you have to take on a few vested interests in the system, and people get their feathers ruffled. But if you go back to the purpose about why we're doing this, those arguments seem to be winnable. I think we are greatly helped by having a crisis. I think it's probably harder for you fighting a battle about 4% increase a year than it is for us at 0% increase a year. But the crisis for you is just playing out more slowly. And
we know that.
Yeah, you do.
Yeah, we know that. Jason, Scotland, I've been to a few sessions here. They've been fantastic. We're actually in Paris. So we should point that out to the people.
You shouldn't point that out because somebody's got to do it.
No, someone's got to do it. You're quite right. And I do remember once someone saying to me, if you don't love Paris, you don't love life. But we have been working very hard here, haven't we?
So I haven't. But, yeah, some of us have. Some of us have.
Good.
Jason calls Paris the Glasgow of the year.
Indeed.
Just
No,
like
I
being at home.
have been up early every morning if that's working.
Let's talk about alignments, Jace, because Scotland, you've really worked hard, haven't you?
So I remember when Jim was telling that story. I remember the day I walked in for the first time to meet our health minister, as a fractured mandible fixer, and she's a very nice lady. But I walked in and met her and said, Scotland is killing people in its hospitals. And she said, oh, okay, what will we do about that? And I said, well, there's this improvement thing. And I think if we do these 15 things and we do them reliably in every hospital in the country, and we start with safety, just because it's an easier message than the whole of quality, then I think we can fix it. And to cut a long story short, she said, oh, okay. Now, I'm not one political party or another, but the courage of a politician to then go to the Parliament in Edinburgh and say, basically, we are harming too many people in our hospitals, but here's the news, I have decided to do a thing that's going to fix that. And the opposition politicians all shout, and she holds the line and says, no, we're going to reduce inpatient all-cause mortality by 15% in 5 years. Now, I always knew that safety was a Trojan horse. People like Jim and Frank and others have taught me how to do quality in a strategic way. So I knew that if I got safety in, we would then be able to have an efficiency conversation. We'd be able to have an effective conversation and a person-centred conversation. And that's exactly what's happened. We got currency in leadership by reducing mortality, by getting rid of central line infections, by eradicating other harm. And now we're able to have conversations that say, so how do we make the care better, the actual care? How do we get rid of visiting times? How do we make nutrition better for patients and families in our children's hospitals? And how do we make the community care relate better to the secondary care? So now we're having conversations that were unthinkable 5 years ago. And I think it's partly because we've had that leadership from the very top. Now, we've also had consistency because our health minister's been in place for 5 years and is going to be in place for another 5, unless something dramatic happens. So the conversation I now have with her is the same conversation. It's the same people in the same corridor, and we have some optimism because we've done stuff. And that's beginning to feed its way through the chief executives, through the clinical leaders. It gets a little stuck, I have to say, at the middle.
The middle point.
The middle treacle. And then it gets really good traction again at the front line. Because the front line love the surgical checklist. They love putting the beds at 30 degrees because they can see the results on the wall and they've made significant change. And now we're moving to primary community care where they're putting their results on the wall and they can see the change. But I'm still challenged with the infrastructure that we've created to drive our system in the middle.
Frank, you've worked with people all over the world. This issue of alignment. How does that play out? I mean, you're an American. You've worked with many American institutions. The American system seems pretty complicated to me.
Pretty broken.
Yeah, but broken. Yeah.
He's got an Italian heart.
But
Yeah, the incentives are varied, financial, clearly. As you know, in the United States now, there are certain conditions you will not be paid for if a patient is readmitted with congestive heart failure or a pressure ulcer develops or an infection. So that's put some pressure on the executives. There's another component, I think, that's coming. It's the patients and what they're expecting. And the patients are going to put pressure to say, if I have a choice, I will take it. Or I will demand from you that you give me the service that I should be getting. Now, many patients will not stand up and say that, but there'll be that undercurrent and there'll be that social movement where it becomes the tipping point where more and more patients.
It could be the game breaker, couldn't it?
It definitely is. We at IHI are constantly learning about patient engagement.
Yeah.
And there are different layers of engagement. Clearly, there's engagement with your own care, and patients should be helping to decide and participate in what they choose. Engagement in developing the improvement processes. What is it that you're improving on your unit that a patient might give you some insight that you might do it differently and might do it even better and give the patient some satisfaction. And then there are patients sitting on boards or on large committees. At Dana-Farber Cancer Institute in Boston, patients interviewed the new incoming chief operating officer. and decided whether or not that person would fit. So you can see there's a tipping point for that. I also want to mention the alignment of incentives for the middle, because it's true. Working with middle managers, what are they being evaluated on? Productivity. Keep the train running on time. And how do we change that? And as leaders, so not only do you incentivize the whole institution, but you've got to think about that middle layer. How am I governing them, and that middle layer now can feel this is important, because that tension winds up with frustration at the front, frustration at the top, and you have to resolve that.
I mean, these are great examples about patient engagement. I think, this is a personal view, I think around the world you see us getting better at bringing patients into our system, which is good, but the real change will come not from inside systems, it'll come from outside. It'll come when social movements organise in healthcare in the way that strangely they seem to have organised in almost every other walk of life, and the professional and knowledge barriers seem to be so powerful in healthcare that it's taking longer for people to kind of get hold of the tools. But it's coming, and I think we should, it'll cause us hell. It'll cause us the right kind of hell, and we should encourage it by doing things like that these guys are doing and we're trying, like the publication of more information. I still meet healthcare systems around the world who are committed to improvement but frightened of transparency of data. And that's a very powerful telltale about where we are on our patient engagement. In other words, we still believe in many systems that we can understand the data, but it's somehow too complicated for someone else called the public, which seems to be us, to do it. And I think the thing we can do is the work inside organisations, which is great, but I think we'll always, even when well-intentioned, butt up against our attitudes about patients giving us useful advice, which is different to patients having control. But if we begin to just liberate the data about safety and quality, I think that will feed into these new technologies about engagement, and there'll come a point when we are having to respond exactly as Federico describes, to patients saying, hang on, these are our expectations, and that will be a very, very powerful driver for change.
The issue of collaboration is a really interesting one for me, in the sense that, Frank, you've talked about collaboration within an organisation. Scotland, interestingly, you've got a whole of nation approach to this work. So you've got, you've overcome, sort of what I can't imagine wouldn't have been significant barriers.
I have numerous anecdotes that would describe exactly those barriers, but we'll maybe not give you them.
So how did you manage that? Because that's
we have
a challenge we have.
So we have the only thing Jim Easton looks at me enviously on is my scale. I mean, poor Jim has 50 million people, and we have 5 million. So we have a significant advantage of scale.
And people tell me that Nigel Edwards in his talk this week was saying that he thought kind of 5 to 10 million was almost the perfect scale.
So you're almost stuffed, Jim. I mean, it's hard. So
although I did meet the Chinese healthcare system recently, that
put yours in perspective. Did they offer you a job?
No.
So the Scottish healthcare system is manageable. So infrastructure-wise, I and the other directors of the system meet the chief executives once a month. All of the chief executives once a month.
All of the chief executives.
Gather in a room.
And they all show up.
And they all show up.
We even at our scale, we meet all of ours 4 times a year.
Don't they say they're so busy they can't come?
No, they don't. Because although we don't, I suppose, in terms and conditions sense, directly employ them, they feel part of the brand.
Yeah,
they are the NHS Scotland brand. Our health minister meets with the chairs of the boards once a month. So if you use that lever wisely, you can have a conversation that says, okay, what's the agenda for that meeting? Is that agenda all about the 11 billion spend? Some of it is, of course it is, quite rightly. But some of it's also about how are your safety results? How is your capacity building? How is your value proposition? What can we do to build capacity? So we've run, with IHI, some board education events that have taught non-executives and board chairs how to be better board members. And that comes from that infrastructure. So there is something about our scale that gives us an advantage.
I'm sorry to interrupt you, but in my mind, I am really clear about this idea of I'm too busy to collaborate. And the answer is it's a disgrace. It's endemic in many healthcare systems, and it's been a problem in ours. So the story I would tell is when I was a trust chief executive in York, pretty good trust, next door to a trust in Harrogate, which is a small, high-performing trust, and we would do anything rather than learn from them, anything, until we decided to get over ourselves and do it. You're more likely to meet people from England learning in an international conference than you are learning from their neighbours. And don't call yourself a leader of quality improvement. Don't say that you care about high quality patient care if your model is that you're going to learn every solution yourself. It's clearly ludicrous. Do you mind if I say something about England-Scotland? Because the current equivalent of that is England-Scotland.
Yeah,
typical relationship between partners. There is a lot of love there. And also kind of all sorts of historic rivalries, politics that's kind of peeling apart a bit between the two nations. And one of the things that Jason and I are determined to do is get some learning going between these two nations.
And it's hard.
And it's hard because it plays into the politics and the logistics, but we're going to do it because if we're not showing that there's stuff to learn, some of the fantastic work that Jason's led on safety and central line infections, and similarly on the other side on efficiency, then we can't go out into our own system and talk about it being a disgrace. So the issue is, as individual leaders, you can change it in a moment by just deciding that you are going to demonstrate that you're prepared to learn from your neighbours. And if you don't, then you're an arrogant, self-interested person who talks the talk about putting patients first, but not enough to learn from other people. Have I said that clearly enough?
No, I think I've got that.
I'd like to make a comment
please,
as well, because working with some organizations, you choose to make the time. Working with one group in particular, all the chief execs were saying, we don't have time to coach the teams, we don't have time to learn what's going on, we don't have time to go to meetings and learn from each other. And then one chief executive said, no, it wasn't you, no. And one chief executive said, I will find a way to make the time. And they called creating it white space. And they've purposely created space where they now can go and visit the different wards to see what's going on. And the culture change that occurs is just wonderful because now they're visible. And this is even more than just executive walk-arounds. This is actually spending a good amount of time. Show me what's going on. What are the things getting in your way? And demonstrating that they're totally committed to that. Because without that, if the flag bearer is not leading the way, folks aren't going to follow.
And I absolutely agree with that. And I again, I'm mood of being relatively clear. I don't believe time is ever the problem. When people say they haven't got time, what they mean is they don't think it's important. People have time to do the things they think are important in their lives. When they haven't got time, it's really saying, I don't value this, it's not a priority for me. And that's the problem to solve. As soon as it becomes important, we all have the time in our lives to do the things that matter to us.
But I think that it would be unfair to pick solely on chief executives in that regard because this is, we're so busy, and actually everyone is so busy.
So we've had a really interesting conversation this week about partnership with IHI and the other organisations who are here. And so the Danes are here, the Swedes are here, and Scotland has a relationship with all of these organisations. But we're now thinking how. So I know all of the leaders within those systems. I can phone them. I don't need IHI. To make those connections, it's done. What we don't have is the critical care doctors in my organisation able to phone the critical care doctors in Denmark or in York and we need to create that kind of network. So the leaders network kind of happens to some extent, and we're getting better at that leaders network. So Jim and I could phone each other tomorrow, Frank and I could phone each other tomorrow. But what would it mean for a staff nurse in a little rural hospital in Scotland to have a colleague she could speak to in York or in Copenhagen or in Wellington
or in Auckland,
correct,
or in Christchurch?
So how do we create that kind of network if we're all on the same journey, if we're all learning the same stuff? Why do we repeatedly relearn?
Should we all look at the camera now and commit to doing that
and pledge?
Should we pledge? Can we pledge?
Right.
Okay, let's look. Okay, we are going to pledge that we are going to make those networks happen, and we're going to do that. And we'll do it. Should we do it in the critical care space to start with?
It's certainly the place I have
We've got
I have the best results.
Okay,
so
we
that's
have a national
collaborative.
the commission is running with us at Ko Awatei, but the commission are running this collaborative, a national collaborative on CLAB, on central line associated bacteremia. Why don't we organise a get together? We could video conference.
So we have people who can do that.
Yeah,
easy.
Let's do that. Okay. All right. Okay. I think that we might start to wrap this up a little bit now. I'd like to thank our guests for giving up their morning coffee and croissant, because it is breakfast time, to speak with us. I hope you've enjoyed the conversation. I think there are, some very clear pointers here You know, we do not have to reinvent the wheel in New Zealand. We're on a journey now. We're doing some very good work. We have the opportunity to accelerate that work and to focus it even harder with the help of our colleagues and the tips and the advice that they have given us. We've heard a bit about alignment, we've heard a bit about capacity building, we've heard a bit about leadership, and we've heard about how we relate that to performance around goals and clear measures. And they are in the priority areas that we've set. So I think I'll thank you, Jim, thank you, Jason, thank you very much, Frank. Thank you very much indeed. And enjoy the day. I hope you have a great time. And we'll see you soon. Bye. We're going to go back out onto the floor.